We gather here today to launch the first single-payer healthcare system in America.
Vermont State Legislature, the governor, and the congressional delegation are able to work together effectively, and I believe we will. We have a golden opportunity today, not only to significantly improve the healthcare system in the state of Vermont, but equally important, be a model for the rest of this country in moving America forward in a very new direction. Vermont can lead the nation.
Vermont went a very different route. You had this rare joint session of the legislature with your whole congressional delegation. And you were addressed by a Harvard consultant, an economist, who laid out different proposals for single payer. You are leading this charge, Governor Shumlin. Why?
The biggest challenge for business in Vermont, or one of them, is the rising cost of healthcare. And I think what we want to do here in Vermont is to create a single pool, much like General Motors, Ford, Oracle, ensure that healthcare is a right and not a privilege. My vision is that if Vermont can get this right, the other states will follow.
Well, the first thing that people need to understand is that single payer in Vermont is really about single payer nationally. Single payer is a national movement. There's an agenda on the part of a lot of folks who feel very strongly that socialized medicine, a government-controlled monopoly medicine, is where the nation needs to go. And being able to prove that point or demonstrate what they believe is the solution to our healthcare delivery and finance problems is a very, very difficult thing for people to do. So they need a laboratory, they need a place to test their theories. And since Vermont has become so willing, if you will, to be the petri dish, to be the laboratory for many of these very ultra-liberal kinds of concepts, social engineering concepts, if you will, this becomes the logical place to give it a try. And given the election outcome from 2010, where we had, for the first time, the governor and a leadership in both the House and the Senate, for the first time in the history of Vermont, all of the levers of power, legislative and executive branches, were in the hands of people who were long-standing supporters and advocates for single payer. So that was the alignment of the planets that made it possible for Act 48 to be passed and to put Vermont on the path to demonstrating, for good or ill, whether or not single payer is something that the nation should embrace.
Dr. Richter, did you actually move from Buffalo, New York to Vermont for this purpose, to get one state in the nation to pass single payer? And why did you choose Vermont?
It was one of the major factors as to why we moved here. I was trying to do advocacy to get a single-payer healthcare system in New York, very naive of me, I think, and realized I was spinning my wheels in New York. And I really, at that point, felt that that it needed to happen in one state or several states, and I figured Vermont was a wonderful place. So it's very accessible, and there's only 300,000 voters in Vermont. So it seemed like, why not? It seemed like the right thing to do.
It is amazing that the federal government would think that the 630,000 people in Vermont would need in excess of $200 million just to put the machinery in place to do this. It's rather amazing when you think about it. So the notion that the federal government might come up with $1 billion to give single payer a boost come 2017 is not a crazy thought. It's entirely possible, especially with the current administration in Washington. It's entirely possible.
I happen to be a proponent of a single-payer universal health care plan.
You put $1 billion down over 3 or 4 years, and single payer can actually look pretty good for a few years. You can make it look like it's working. It's going to be eating the seed corn, but you can make it look like it's working with enough free money. And it might look like it's working just long enough to give the national advocates and the advocates that exist in every state in this nation the influence they need to get other states to do likewise. The Vermont single-payer model is taken directly after the Canadian model. And what we haven't done is we haven't studied what works and doesn't work in Canada to any great degree. Canadians are certainly well aware of it, and the information is there for anybody to see. We need to take a very close look of especially the failures of the Canadian model before we repeat them here, because we can certainly do better.
The push for single-payer system in Vermont, to put it in Shap Smith's terms, is Vermont has every intention to become what is known the Saskatchewan of the U.S. Now, Saskatchewan was the province in Canada where the single-payer system started out and then metastasized from there and became a federal system.
Vermont single-payer is not an original idea. In 2010, a filmmaker named Logan Darrow Clemens was prescient enough to document the troubled Canadian system in a movie called Sick and Sicker.
Canadian politicians didn't mess around. They simply outlawed private health insurance and took over.
And his name was Tommy Douglas. And in 1944, he came up with the idea of universal health care, a single payer, got rid of all this notion of having insurance companies involved in health care.
If I am a citizen and I want to buy health insurance and somebody wants to sell it, you believe it's right for the government to step between us and say, no, you two shall not trade.
Not only do I believe that, most Canadians believe that.
So you believe each person has a right to health care?
Absolutely. Yeah, quality health care though.
Let's take a look at some of that government quality health care. I know it must be good because Canadians are always waiting for it.
So we end up having to just go to the walk-ins and wait hours and hours and hours, and you never know who you're going to get.
So you can't get a family doctor?
I cannot get a family doctor.
And there are studies done that, almost 80% of family doctors in Ontario are not taking on new patients. And I pay my secretary an hour a day just to handle calls from people begging to get into my practice, explaining to them what's going on, who they can speak to. But it's very difficult for the patient.
I go down to the cancer clinic and you find almost standing room only, people waiting. There's something wrong with a system like that.
I used to work in a remote area for 5 years. And I remember that when a doctor came to open a new cabinet, there was already people waiting in line the same day he arrived. And in 3 hours, he would fill up his list of patients for the rest of his life if he wanted to.
And then I remember in the Ontario government in the early 90s specifically decided that the problem was too many doctors.
This group of bureaucrats get together and say, well, how do we decrease the number of doctors? Well, first of all, the first step would be to decrease the number of medical school spots.
And they started paying the University of Toronto not to graduate doctors. The size of them went down.
The second step is to decrease the number of doctors already present. Well, they paid doctors $500,000 just to close up their practices.
Provincial government retired hundreds and hundreds of doctors, nurses, technologists, so that they would decrease their budget costs. And this created a hell of a problem in Quebec.
And their theory was if we have fewer doctors, it will cost us less money. And we tried to point out to them that the costs weren't generated by the physicians, they were generated more by the patient demands.
And the medical schools at the time said, if you do this is the early 90s, said if you do this in 10 to 15 years, well 15 years, you will have a huge doctor shortage. It only took about 10. Because now we have millions of Canadians who have no doctor.
There are approximately 300,000 people living in Montreal without a family doctor, but the province of Quebec will only allow how many new doctors in Montreal?
4 to 5.
They deliberately created, and the irony is the people who masterminded this popped up years later as the people who were going to fix the problem that we didn't have enough doctors.
But the problem is our population in Montreal grows by 15,000 every year. And you need 7 or 8 family doctors to treat that population. So, this is not working.
Waiting times are how a publicly funded, open-ended system works. In other words, and the Supreme Court of Canada, hardly right-wingers, have said that when you have, in theory, an almost unlimited demand, you have to limit the supply somehow. And the ways our system limits it is by not giving people timely care.
There are now websites built in provinces by their medical departments of health, that allow people to go and check out what their wait list time is for a medical procedure.
The total number of medical procedures for which Canadians were waiting in 2009 was 694,161. This stadium holds around 67,000 people. If each person was waiting for only one procedure, then imagine more than 10 stadiums, each packed with 67,000 sick Canadians waiting weeks, months, or years for medical treatment.
I run a support group. We have young people now in the group. A 40-year-old who had been having symptoms since she was 25. And the doctor just said, oh, it's just nerves. But you know what? The symptoms are there. They should be tested.
A lot of the procedures take a long time. You know, MRIs could take up a year, 2 years to get one. By then, who knows? You know, you could be in so much pain, you know, might not be able to ever walk to get to the MRI.
Okay, so you were around the middle of January, and they couldn't get an MRI scan to see if you had brain cancer or not until the end of May.
Correct. They are only allowed to do so many per week.
Who prohibits them from doing more MRIs each week?
Government.
We do not have a CAT scanner, which is pretty much standard of care now for most places, but we don't have one here.
We definitely need more PET scans all over Quebec. And these are the latest technology to detect small tumors. So these machines are definitely in shortage in Quebec and Ontario.
If they had better imaging at that time, such as a PET scan, they would not have opened me up, they would have saved money, and they would have saved me a lot of pain and aggravation.
PET scan would have been very helpful, but the Ontario government doesn't hand out very many free PET scans. So the doctor didn't even bother to write the Ministry of Health because he knew what the answer was going to be, no.
What people don't know is that hospitals may have an MRI, but it doesn't mean that this MR is functional 24 hours a day like the States. The budget cuts will make it that most of the hospitals, the MR will function from 8 in the morning to 4 in the afternoon.
So these scans are sitting empty, or else they're doing testing on animals.
So he says, you're going to have a colonoscopy, and he phoned the hospital to arrange for one. This was in June, and he phoned back and says, you can't have one till November, they're all booked up. And I thought, June, July, August, 6 months. I says, you know, the cancer's going to, you know, if I have cancer, which I suspect, it's going to really travel.
So April, May, June, July, 4 months.
So 4 months, and all this time the cancer is progressing.
It spread to my liver. It got worse in my lungs. Yeah, basically it was progressing, and you know, it didn't look very good for me.
It's the only way I saved 5 months by going to the emergency ward on my own.
And what did they find?
That I had cancer in my colon, and they removed about 12 inches of it. And at that time, they found that it had gone a little bit into the liver at the same time.
So just to give you an idea, my drug had to progress for 4 months before they said, yes, John's definitely progressing, his cancer is spreading, it's getting worse. Now we're going to send him for out-of-country coverage. I had to actually have 2 drugs here that did not work before they were going to be able to send me to Buffalo in Amherst to get a drug that does work.
I did go down to North Carolina. I spoke to a doctor down there. He says, we can do this in 3 days. That you have to wait here to try and get into Montreal that has the procedure, they're trying it. You have to wait here for over 8 weeks just to start it. So certainly if I had the insurance in the States, I'd be down there and I would have had the procedure already months ago.
Well, the time that I had to wait, all the time that that I had to wait, the cancer kept spreading in other places. So I ended up with cancer in 3 different places. Instead of having it just in one, it spread to 3 different places.
It took them 6 months really to do anything about it, and by the time I was ready to have an operation, the cancer had further metastasized into my liver.
It took 13 months diagnose and for me to have surgery for my cancer. And for my dog, it was done the next day.
People suffer, and there seems to be this idea that it's okay if people live with pain as long as we don't spend, excessive money on the system.
My basic problem began as a degenerative disc disease, which is a collapsing of the vertebrae. I've been in constant 24-hour pain for many years now, and I asked for an appointment. I got a phone call saying that appointment was going to be in November. This was in October. I was excited that it was going to happen so quickly, but then they told me it was actually in November of the following year. This level of extreme pain that I'm in all the time has severely affected my life on every level, from not being able to work to not being able to leave the house for more than 2 or 3 hours at a time. This neuromodulation therapy that we were talking about is at this point not available to me in Canada.
The longer you have to wait, the more stress there is. And we're not addressing that in any way, in any significant way at all.
We were moving a big server cabinet for a company downtown. My foot slipped and it came down on top of me. With this injury, as time goes by, it gets worse and worse. I can't sit down for a long period of time. I can't lay down. I haven't had a decent sleep since it happened. Oh, we're going on, 7 months now? Somewhere around there. 7 months of this pain. Could be a year before I even get fixed.
They make people for hip surgery and knee surgery wait sometimes years. Cancer patients don't have that option. The oncologist referred me to the surgeon. He suggested a process called radio frequency ablation. In the rejection letter, whole hip, basically, they said it was experimental and it was not an accepted procedure. They make it so ambiguous that it's a catch-all phrase. And if it's something that they don't wish to cover, then it's covered by experimental. We went to the appeal board hearing. The board ruled in my favor. They found that the procedure was not experimental. My biggest fear after the whole thing was that they would reappeal. They will spend more on the legal fees and lawyers than what the original claim was. That's everything I had, everything I've collected in my fight with OHIP.
The emergencies are swamped. Then when we do have patients come in with a fractured hip, they may wait 3 days in our emergency before they get up to the OR.
You'll have periods where there are a frighteningly few ambulances covering all of Toronto. It is terrifying.
Our military in Afghanistan was criticized for torturing their captives by putting them on a stretcher in a brightly lit room for 24 hours straight. Well, we put them in a brightly lit hallway for 48 hours straight, 72 hours straight, and they have a very painful right hip because it's broken.
There are cases of relatively rare where people come in to emerge and wait so long that they die.
Apparently, Charlie had been here out in the workshop using a side grinder, and his clothes had become ignited and caught fire. He had third-degree burns, and at that point we met Dr. Gibson, who is the anesthesist up here.
They were third-degree burns, roughly 30% of his body. It was the left side of his chest, left side of his back, his whole left arm, left face, left neck. We had called Critical and asked them to try and find us a burn unit, and they'd been in touch with all of the ones in Ontario and said there are no burn beds available anywhere in the province. The plane arrived at 10:30. And then we finally got loaded in the plane and took off for a short flight across the lake to Rochester. And he arrived at the hospital there around 11:30 that night. We're getting ready to do skin grafts on him the following day, and the Ontario Ministry of Health phoned and said, no, wait, we want him back in Ontario now. We have our staffing issues settled. We'd like him back in Sunnybrook Hospital in Toronto. And the staff in Rochester apparently said, look, he's way too unstable to be shipping back at this stage. We'd like to start with the skin grafts, and the word was, no, don't do that. We'll do that when he comes back. And it was about 4 days later before the transfer was actually possible to get him back to Ontario. He arrived here in our hospital at 3:15 in the afternoon. He got to a burn unit at about 11:30 that night, and the skin grafts were 4 days later.
I really think that Charlie's delay in the skin graft issue, or delay before it was started, was a matter of economics. I think the bureaucrats didn't feel that they wanted to, whether they thought it looked bad that he had to go to Strong Memorial, or whether I think it came down to dollars and cents.
To think that you put your medical system, an industry, in the hands of politicians and think that it's going to serve patients is presumptuous.
What we're talking about is that we have serious problems that we need to address. But the problem is that no politician wants to drive, because it's the third rail of Canadian politics. You touch it and you die.
I think most of the politicians have about a 4-year horizon. They can see what's happening between now and the next election, but they don't seem to be able to look beyond that.
Political capital is what the politicians do not want to spend. Deaths of patients, injury to patients, that doesn't bother them too much. Political capital is what they don't want to spend.
So why didn't people buy private health insurance in Quebec?
Because it was prohibited.
If I had paid someone to do it, I would have gotten a $50,000 fine and up to 12 months in jail, and the professional that provided the service would have gotten a $200,000 fine, also with 12 months in jail.
In Canada, healthcare insurance is outlawed, so none of our clients have healthcare insurance. They pay out of their own pocket. Many of them have mortgaged their homes.
To suddenly look at your husband and realize that he's had to take a second job, put a second mortgage on our house. But I don't think it's a decision or a choice that any family member should have to make. I was fortunate that my family made it. Okay. The money part gets to me.
I can spend as much money as I want buying booze, smokes, cigarette, tobacco, liquor, gambling. I can spend all I want. But if my child is sick, I can't spend any money of my own money to go and heal my child.
If you think health insurance is expensive now, just wait till it's free.
We don't have a free public health care system. You're all paying an enormous amount of it through your taxes, and frankly, we're running out of money. We're running out of the ability to fund this system properly.
Every $100 per capita that the Canadian government spends on health care, the waiting lists increase, not decrease, they increase by 1 week. And what is happening is there will be an announcement with great fanfare that the government has increased spending. All of the people who had completely given up hope of ever getting treatment in Canada rush to their doctors, clutching the newspaper report that there's now more funding available for people for their condition. Their doctors refer them to specialists. The specialist lists get longer by 1 week for every $100 increase per capita.
Budgets are exploding. Healthcare budgets are half the budgets of most provinces now, and they're steadily rising.
companies now are selling their services to link up ill Canadians so they can find medical services and procedures and programs in other countries like in the United States or in India or Pakistan or China.
They phoned Northtown Images in Buffalo and arranged for an MRI the following day.
I contacted the Mayo Clinic in Scottsdale, Arizona.
My sincere hope is you keep your system in the U.S. And continue helping our Canadians who are unable to get care in our existing government monopolistic system.
Should America adopt the Canadian healthcare system?
Definitely no. American patients are going to suffer, and some of them are going to die.
Now that we have seen the fiasco of the rollout of Obamacare and the website and also the Vermont Health Connect, it's a fair question to ask whether we can trust people who can't make a website work with control over our entire healthcare system. And under single payer, that's exactly what we're talking about. We're talking about control over the funding, control over the distribution, control over all of it, insurance, delivery, the entire system becomes under government control.
The Commissioner of Vermont Health Access puts it well.
Our system is so fragmented and so complex that nobody's in charge of it. And the Green Mountain Care Board is an opportunity for us to create strategic leadership in our healthcare system to be able to focus on both access, quality, and cost.
And if they can't make the